Thank you. Thank you to the organizers for inviting me. I'm so sorry I'm not there with you, but this is lovely that it can be done remotely. So the title really is a challenge in that I think we think we understand a whole lot more than we do, and it's an encouragement to really keep probing and keep an emphasis on understanding basic immunology, and then of course as that applies to the clinical settings. So here's my disclosure and disclaimer. I think we've all come to realize that we are at an unprecedented time in history in terms of being able to manipulate the immune system. On the one hand, to treat cancer and chronic infection by maximizing maximizing effector function, minimizing regulatory function, and on the other to treat autoimmunity and graft rejection by doing quite the opposite, maximizing regulatory pathways and minimizing effector pathways. So I think we all, from very good basic research, understand that T helper cells are the limiting factors in generating immune responses to protein antigens, that in general, B cells are not driven to form plasma, antibody secreting plasma cells or memory B cells without intense interaction with T helper cells, particularly in T follicular helper cells. And in fact, T cells are much more robustly tolerant than B cells to self-proteins. It's amazing that I'm presenting a slide from 1980, but this is an amazing piece of work whereby proteins are arrayed in terms of their concentration, and the percent of T cell tolerance versus B cell tolerance is shown, and one can see that T cell tolerance extends out to much lower concentrations of self-proteins than does B cell tolerance, and this is extremely important in autoimmunity. Moreover, T helper cells are critical for generation of cytolytic T cell responses, which are increasingly important in terms of gene therapies and transplantation. So why is this? Of course, the enhanced tolerance of T cells have to do with thymic mechanisms for imparting T cell tolerance, and there are two predominant ones. One, of course, is the generation of FOXP3 positive regulatory T cells in the thymus, and these horrible experiments of nature have revealed this in patients with AAPS, which has to do with a mutation in FOXP3. It's X-linked, and so the mother gives her son a bad copy of the X chromosome, and that is a mutation in FOXP3, and he develops autoimmunity, inflammatory bowel disease, and allergy. The second mechanism in the thymus is really fascinating, I think, which is has to do with autoimmune regulator, which is another transcription factor. It promotes expression of peripheral tissue antigens in the thymus, and mutations in this transcription factor are associated with another autoimmune syndrome. And so the thymus really does two things. One, if there's a high enough affinity interaction between a developing thymocyte and thymic epithelial cell, one gets clonal deletions, so you completely lose that autoimmune specificity. But if the affinity is a little bit lower, one can get clonal deviation to Tregs. So that really, these thymic mechanisms are critical for generation of tolerance and enhanced T cell tolerance. As well, there are peripheral mechanisms for generating Tregs. So the iTregs coming from the thymus, which are marked by neuropilin-1, that's one mechanism, but Tregs can be generated in the periphery depending on the antigen presenting context for naive T cells. And the mechanisms by which Tregs suppress immune responses are numerous and ever growing. And, you know, I think that this has been well explored in a number of circumstances, and certainly secreting inhibitory cytokines, metabolic disruption. Tregs express high levels of the IL-2 alpha receptor and so sop up IL-2, depriving T cells, other T cells of the necessary growth factors for expansion, targeting dendritic cells, turning them into tolerogenic dendritic cells, and lastly, by cytolysis, perforin-mediated cytolysis. So let's begin with the idea of manipulating the immune system in terms of trying to mitigate autoimmunity. And the example here is treating refractory multiple sclerosis, an autoimmune disease, by blocking the IL-2 receptor alpha. And so the rationale here is simple, that the IL-2 receptor alpha is transiently expressed on CD25 effector T cells, and of course it would do so for these T cells that target the myelin sheath. And so daclizumab, an CD25 antibody, was approved by the FDA for relapsing MS after inadequate response to 2 other agents. And what it was found was that the annualized relapse rate was lower with daclizumab than with interferon beta, to which it was directly compared, 45% lower rate. New or newly enlarged hyperintense lesions on MRI favored daclizumab. And there was no difference in disability progression. Where there was a difference was in the higher incidence of serious adverse events in the daclizumab versus interferon treated arm. And that included a substantial amount of autoimmune adverse events. And so was that surprising? Maybe not, if one goes back to the very basic aspects of interleukin-2 and its alpha receptor. So it's a two-faced cytokine. It's the prototypic T cell growth factor. It's required for initiating clonal expansion of T cells, hence its reason for targeting in autoimmunity. And as I mentioned, it's transiently expressed on effector T cells, but interestingly, constitutively expressed on regulatory T cells. And when you look at the mouse data, the knockout of IL-2 or the IL-2 alpha chain of the receptor in mice didn't result in immune deficiency, but rather in systemic autoimmunity and lymphoproliferation. So a big warning here. And in fact, when it was approved, there was a REMS developed, and it was cognizant that this might be difficult. In addition to the mice, there are more experiments of nature in humans, and this is one in which there was a congenital deficiency in IL-2 receptor alpha. And here's a patient who had numerous infections, probably due to the lack of activation of CD20 of effector T cells, but also this patient at age 5 developed immune-mediated biliary cirrhosis, something seen in autoimmune disease, usually in much older women. You can see the infiltrate around the portal tract here. So, what was the autoimmune clinical signature of this product? Among 2,000 treated subjects, there were 5 deaths attributed to autoimmune hepatitis, cutaneous drug reactions, and intriguingly, worsened MS, 1 case of fulminant hepatic failure, 11 cases of liver injury that was related to this product, and intriguingly, the median time to onset after the start of the therapy was about 13 months, okay? And so that is very telling and not surprising, as we'll see. After administration, we know of this IL-2 antibody, the recovery of Tregs is gradual over a 6-month period of time, and it can extend till after recovery of the autoreactive T cells. And this certainly does explain a long time to onset of some autoimmune adverse events, and in fact looks a lot like the kinds of immune-related adverse events pertaining to checkpoint inhibition, particularly with anti-CTLA-4 monoclonal antibody. And one can see here that the time in weeks to development of these, you know, it starts 7 some even longer, and extends out considerably. So this really has the appearance of checkpoint inhibition and indeed to depletion of regulatory T cells. And so basically, as the product was used, there was an evolving benefit risk profile. And I think we need to remember that at the time of approval, there are a minimum number of patients treated. Once it gets out into widespread clinical practice, it goes into many more people, and one can start seeing a different picture of adverse events. And so, again, the emphasis really is important to think about post-marketing. And so there was an EMA report of 12 serious inflammatory brain disorders following use of this product. And so for that reason, the manufacturer and FDA collaborated in withdrawing this product from the market. Again, what happens following approval is really critical, and fortunately, not more damage was done here. But this does bring up the topic of these very exciting evolving approaches to immune tolerance induction to treat autoimmune disease. And how do we define tolerance induction so we're on the same page? So it's broadly defined as a selective elimination of pathogenic immune responses to a relevant antigen by any of a variety of approaches while preserving protective immunity, and does not require ongoing treatment with the intervention. And one can think of a number of modalities here. There's certainly antigen-specific approaches, there are antigen-targeted approaches, and there's global immune system reconstitution. And I just want to highlight some of the safety issues that may be associated with antigen-specific and targeted therapies. So in the antigen-specific scenario, antigen is the bait. And antigen-specific lymphocyte populations really should be the sole catch. And there's a number of modalities here, including allergenics, et cetera, that are really coming into prominence now in terms of clinical investigation. And the safety concern, really the major one, is that the potential for in vitro or in vivo conditions to convert tolerance induction to immunization in the setting of robust inflammation. So it may require you know, and we need to get out of our magic bullet thinking, but it may require, before these kinds of treatments, that one deals with the robust inflammation in auto-inflammatory disease. So we're thinking combination therapies here. The route of administration effects. What if IV confers tolerance, but if it leaks into the subcutaneous space, you get immunity. So that's an issue. The presence of innate immune response modifiers, either in the product or at the site, damage-associated or pathogen-associated molecular patterns. The intercontrovertibility of regulatory T cells to Th17, one needs to be sure that the Treg-specific demethylated region is in fact demethylated and stays that way. And critically, I think, especially for this group, product stability within the formulation and in vivo. So the changes that can occur in the context of a formulation, and particularly one in vivo, including aggregation, deamidation, et cetera, are really very critical. And I have an example, and this may not be one in which the formulation actually changed the product, but here's one in which the human growth hormone depot preparation was developed, in which there were micronized particles of growth hormone placed in these microspheres. These are PLG microspheres. And one can see that compared to the non-depot preparation, the antibody rate to growth hormone was quite low in the non-depot preparations, but it went dramatically higher in this preparation in which there were particles of growth hormone in these PLG microspheres. And you know, the issue here is not one that these PLG microspheres converted a soluble product into particles, but that could be a scenario, and really one to focus on, because microspheres and nanospheres are increasingly evaluated in the context of antigen-specific tolerance induction. So what about antigen-targeted modalities? So in this scenario, the therapeutic targets lymphocyte populations broadly, but specific antigens are targeted by the close proximity of the tolerance-inducing therapeutic in time and location with both immunologically relevant cells as well as the target antigens. And some examples are low-dose or antibody complex IL-2 to stimulate regulatory T cells, non-FC receptor binding CD3 monoclonals, which induce T cell exhaustion, potentially in T cells mediating islet-specific autoimmune responses, rapamycin-loaded nanoparticles, which really focus on generating tolerogenic dendritic cells, and polyclonal Tregs. And of course, the safety concern here is that you could get more global immune suppression than you would like. It raises the question of tolerance induction to pathogens, as well as effects on tumor immunity. And of course, there's a bigger efficacy challenge here, which is the failure of a broadly targeted therapeutic to achieve sufficient dose in relevant tissues and time frame for efficacy. So a big challenge here in terms of efficacy. So, okay, I'd like to switch now to the opposing aspect of manipulating the immune system, that to treat cancer and chronic infection by maximizing T effector cells and minimizing regulatory T cells. And of course, there's a number of modalities here: monoclonal antibodies to checkpoint inhibitors, chimeric antigen receptor T cells, inhibitors of indolamine dioxygenase, and affinity-modified tumor-infiltrating T cells. And so in terms of the checkpoint inhibitors, there's really a hierarchy. And the major ones, the CTLA-4 and PD-1 pathways, have been targeted most heavily. Now we're starting to see use of co-administration of some of the more minor checkpoint inhibitors, which are associated with less toxicity than the CTLA-4 and PD-1 checkpoint. And so in studies thus far, there really is synergy and blockade of these pathways. We've certainly seen it with PD-1 and CTLA-4, and again, it's increasingly being explored with the more minor checkpoint inhibitors. So immune checkpoint inhibitor therapy is indeed, can be more effective when blocking multiple checkpoint molecular pathways. And so you can see that anti-CTLA-4 and anti-PD-1 produces a higher objective response rate in patients with melanoma than does either alone. Of course, there are numerous factors contributing to resistance. You can see that the objective response rate isn't wonderful, and the complete response rate is actually quite dismal. And I think, you know, we've been so excited by the fact that you can get spectacular responses in patients who you know would have been given up for gone with the current therapeutics, as well as an occasional complete response that we really haven't focused heavily on enough on the factors contributing to resistance in immunotherapy. And of course, you know, low TIL infiltration, low non-synonymous mutation burden, epigenetic silencing. This, I think, is going to be huge, because it's I think, becoming increasingly clear that this is very prominent, and especially with tumors having the capacity to epigenetically silence targets for the immune response. But one thing, and especially something of importance to this group, that I think goes perhaps unrecognized, is the fact that patients can develop anti-drug antibodies to these checkpoint monoclonals. And so, in fact, to the single agents, there's a surprisingly low incidence of anti-drug antibodies where it's been looked, and that's with the release of a break. But there's a much higher incidence when when there's dual checkpoint inhibition, when the brakes are released. So, for instance, the immune response to anti-PD-1 antibody is 11%, and that's not neutralizing. But when you combine anti-PD-1 with anti-CTLA-4, the rate goes up to 38%. That's substantial, and approximately 5% of those are neutralizing. And the same with focusing on the anti-CTLA-4, fairly low incidence when used alone, but when combined with the anti-PD-1, it goes up. So I think this is an area we really need to focus on more because there are mitigating pathways for this kind of non-response. And I really question whether this low incidence is a function of immune dysfunction from numerous treatment courses of chemotherapeutic and other agents, targeted agents, prior to immunotherapy. So most of these immunotherapeutic agents have been used in as third or fourth line treatments. And so it could be that the immune system is so hobbled by then that the rates are relatively low. Now that we're starting to see these immunotherapies being used as first and second line therapies, it will be very interesting to compare the rates. So, and here's a cautionary tale, and just to remind us all that anti-drug antibody responses do not always negatively impact safety and efficacy, because sometimes, and it really has to be looked for because sometimes it gets missed, that neutralizing antibody can act as a chaperone or a carrier for therapeutic proteins, enhancing PK, potentially enhancing product activity and efficacy. And such favorable antibody responses, the problem is they're not predictable, they're not controlled, and they may represent a metastable or unstable state. And really this requires intensive study. It does suggest novel approaches to formulation, which are increasingly being explored now. And just as an example of this was an enzyme replacement therapy, L-isophase alpha, for Morquio syndrome. And in this scenario, it wasn't clear that neutralizing antibodies were friend or foe, because all patients developed anti-drug antibody, and the titers were sustained or increased over 72 weeks of treatment. By week 16, 96% of patients developed neutralizing antibodies capable of inhibiting the drug from binding to the mannose-6-phosphate receptor. However, instead of enhanced clearance of the enzyme replacement therapy, clearance was delayed. So one saw the area under the curve, and the Cmax increased dramatically at week 22 compared to week 0. The half-life increased from 7.5 minutes at week 0 to 36 minutes at week 22. So this suggests that in patients mounting these responses, antibodies acting as a chaperone. Now, whether the enzyme replacement therapy dissociates from antibody and binds to target tissue, that's not at all clear, because since all patients developed anti-drug antibodies, there are no available data to assess the relationship between antibody development and therapeutic response, and whether immune tolerance induction could be beneficial in this scenario. So, getting back to cancer and infectious diseases, based on the enormous success in cancer, PD-1 blockade is often proposed as a therapy for TB. And here's a cautionary tale. So a TB lesion, a granuloma, looks a whole lot like a tumor, with the TB in the center of suppressive macrophages, and surrounded by T cells, which can't seem to penetrate very well. It's also well known that CD4 T cells and interferon gamma are critical for control of TB infection. So this seems a natural, you know, in patients with TB and granulomas, blocking PD-1 may unleash a better response to TB. But in fact, what it did was to unleash early mortality. And this is a study in PD-1 knockout mice. And you can see that when you infect PD-1 knockout mice with TB, they have dramatically early mortality. And that it's due to the CD4 T cell response, because in these PD-1 knockout mice, when you administer anti-CD4 and wipe out the CD4, those animals survive, and you can of course see the dense infiltrate in the lung of these animals, and that's eliminated by CD4 treatment. So in this circumstance, PD-1 treatment, anti-PD-1 treatment actually is devastating, and in humans there are case reports documenting TB and worsened effect after PD-1 blockade for cancer. So I listed a number, but here's a pericardial tamponade caused by a response to anti-PD-1 treatment in a patient who had pulmonary adenocarcinoma. So numerous examples, and in fact there is a, the product label of the anti-PD-L1 indicates that mycobacterial infections were observed. So a big note of caution. Cancer does not translate to chronic infection, at least not in tuberculosis. What about chronic viral infection? Well, there were some lovely early studies which showed that blocking PD-1 might be favorable in chronic viral infections. So PD-1 is a marker of exhausted CD8 T cells in mice that have LCMV infection. Blockade of PD-1 in SIV-infected macaques, enhanced SIV-specific CD8 positive T cell and B cell responses, improving viral control and survival. And in HCV-infected chimps, one of 3 animals that received the PD-1 blockade had enhanced responses and a suppression of viremia. So an exciting possibility of here. However, like, again, this is a cautionary tale. There's a lot of complexity in the setting of viral infection. So PD-1 blockade can be beneficial in the chronic setting, whereby you can see a dramatic drop of viral load, basically following PD-1 blockade in animals with LCMV infection in the chronic state. But if you block, or if you give PD-L1 knockout mice LCMV infection, these animals die very rapidly. And the reason they die very rapidly is that the LCMV infects endothelial cells, and you get perforin-driven cytolysis that's directed to these endothelial cells, and it drives the loss of vascular integrity, and these animals die. If you knock out perforin, you get a dramatically reduced death rate. So it's really, again, complexity. We need not to think simply. We need to think about all aspects of disease and what the knockout, the enhancement of immunity could do in each. And this continuation of probing PD-1, for instance, checkpoint inhibitors, is critical. So recently, it's clear that tumors have co-opted the PD-1 mechanism, and it's come to be realized that PD-1 can be a mediator of tumor intrinsic suppression. And who knew this? Well, the mice did. So in this scenario, cancer cells again adopt PD-1, and it's a marker of it's a marker, but it is also functionally suppressing the proliferation of cancer cells. And so this lovely study, recent study, it was found that PD-1 is a haploinsufficient suppressor of T cell lymphomagenesis, and that deletion of PD-1 is recurrently observed in human T cell lymphomas, which frequencies exceeding 30%. So it's highly clinically relevant. Stage 4 cutaneous T cell lymphoma had the highest proportion of deletions of PD-1. And so here you have, you know, the loss of PD-1 correlating with aggressive tumors. And so mechanistically, the activity of PD-1 enhances levels of tumor suppressors and attenuates signaling of tumor proliferation mechanisms. And so, again, the homo or heterozygous deletion of PD-1 leads to rapid development of highly aggressive lymphomas in vivo in mouse models. And so, in a recent clinical study, performed before that study was published, there was a phase 2 trial of anti-PD-1 blockade in patients with adult T-cell lymphoma leukemia who had increased mutational load, overexpression of PD-L1. I mean, a perfect scenario for blocking the PD-1 axis. And so here they describe treatment of the first 3 patients, which resulted not in elimination, but in rapid progression of disease after a single dose. And again, what they emphasized was that, in fact, in mouse studies, it was found that PD-1 was a tumor suppressor, and that, in fact, the rapid amplification of cancer in their 3 patients after a single dose mimicked what was seen. And you can look and see here that you get an enormous increase in HTLV1, the initiator of this tumor, in patients following the single dose of PD-1 blockade. So this is a more general phenomenon with hyperprogressive disease following immunotherapy. So hyperprogressive disease implies a dramatic tumor surge occurring early after initiation of immunotherapy. It's in very distinct contrast to pseudoprogression, which is tumor growth in pseudoprogression is due to increased inflammation, but not in hyperprogression. But rather, hyperprogression is due to a plausible effect of immune checkpoint blockers as enhancers of tumor progression. It's generally defined by a 2-fold increase in tumor growth rate as compared with a reference period. And it's not trivial. It's an incidence of about 9–10% in populations of patients. And it's in a broad spectrum of cancer, not just T-cell lymphomas, leukemias. So tumors are very clever. They really can adopt mechanisms to outwit the immune system. And in terms of correlation, only the MDM2 and MDM4 amplifications have been proven independently associated with this. And this is fascinating because these are transcription factors that regulate p53. So rather fascinating. And here's the definition of hyperprogression. So you can see in comparison to a reference period, the tumor growth rate is 2-fold or more following treatment. And in fact, PD-1 expression, here's non-small cell lung carcinoma, and you can see that either in squamous or in adenocarcinoma, the rate is substantial, and you can see PD-1 expression specifically on the tumor using tumor-specific markers as well as PD-1. So not a trivial phenomenon and something we need to really be careful of. So the last cautionary tale, which is that one of the strategies to enhance the T effector cells mediating tumor immunity is to increase the affinity. So it was noticed that the T cells in patients with tumor infiltrating lymphocytes for lung carcinoma, that the affinity was low, and this is to MAGE A3. So a very reasonable approach is to affinity enhance by manipulating the alpha and beta chains of the T cell receptor to the MAGE A3 peptide in the context of HLA. And so this was done, and an affinity enhanced T cell receptor was generated, and all of the right studies were done at this point in time. The preclinical studies failed to identify significant cross-reactivity of these affinity enhanced CTL on proteins other than MAGE family members, which are not expressed in the adult in general. No overt toxicities in these animals. A blast search for non-MAGE peptides with a high level of sequence homology it really revealed on no high level of cross-reactivity by these enhanced T cells. However, when these enhanced T cell receptor TILs were put into patients, there was a disastrous clinical consequence and heart failure and death in 2 patients. And that was because inadvertently a T cell receptor was created that reacted with a titin peptide. Titin is a muscle protein critical for cardiac and skeletal muscle function. And this had not been anticipated. However, when following this disaster, when investigators went back and looked at the key T cell receptor and HLA contact amino acids in the MAGE-A3 peptide target, there was a defined motif. And in fact, so by alanine and glycine substitution, the T cell receptor amino acids were described as well as the anchor residues. And so homologous peptides using that motif were screened for cross-conservation. And 3 proteins were identified, including titin. So I think this kind of investigation is really going to be critical in all future endeavors to affinity enhance and break thymic tolerance, and an additional, the exploration of this, using some liberal substitutions for amino acids can define even more proteins as shown here. So I'm concluding. The state of the art is that our addiction to magic bullets and past precedents, as set by experience with defined classes of therapeutics, is really an impediment to development of novel strategies based on tumor dynamics. We really have to pay attention to the biology, both of the immune system and to the tumor, and how we have to think non-conventional warfare based on tumor adaptation, either to immune suppression or to the lack of immune pressure, because it doesn't generate high levels of mutations, and novel tumor survival strategies. And with that, I will acknowledge all those who helped with this presentation, and be happy to take questions if there is time. Thank you so much.
Thank you so much as well, Amy. That was a great introduction to a lot of different points there. So I'd really like to open the floor to questions, just so that Amy can see who, or at least so everybody can hear as well. Could I just invite the speakers to come up to the podium to ask the questions so that Amy can also hear? Who'd like to ask the first question? It's all very, very, oh, Priya, great. Sorry, it's not sort of scary to come to the front. That's fine. Okay. If you could just introduce yourself as well.
Sure. Thank you, Amy. That was wonderful. This is Priya Sriraman from Celgene. In terms of neutralizing antibodies acting as chaperones, extending the half-life of a drug, do you think taking serum from these patient samples where the neutralized drug is in circulation and then doing an activity assay using that sample would help us understand whether the drug is truly neutralized, or is it capable of becoming active drug again?
Yeah, it's a really great question, and I think it's a battle of affinity. So if you look in the setting of enzyme replacement therapy, if you look at the affinity of the antibody for the enzyme replacement therapy versus the affinity of the mannose-6-phosphate or whatever other receptors are being used for the enzyme replacement therapy, it may be a battle between those two. Excuse me. But yes, I think in vitro studies could be helpful. Animal studies and animal models are incredibly helpful because you can actually look at whether the enzyme, in this case, accesses the target tissues, and it's better in animals that have this kind, and perhaps taking sera directly, from the patients whether that can actually enhance target tissue penetration, or whether everything ends up in FC receptor expressing cells and is in the spleen and liver. So yes, I think that's a great thing to do. This approach has been used to try and enhance IL-2 for generating Tregs rather than having T cells proliferate or generating NK cells. So IL-2 complex to IL-2, an IL-2 specific neutralizing antibody is being increasingly explored for this. And I think that may be the key to cytokine therapy, which, has been dismal. Cytokine therapy, why doesn't IL-10 work? We're all stuck in the drug model. You stick it systemically, you hope it gets to the right place and the right amount to cause an effect. But in point of fact, that doesn't happen. We have to think better about targeting, and this may be one way to do it.
Thank you. Yeah.
Thank you.
Any other questions? So, Amy, one final question from me was in regards to sort of tolerance induction strategies. And do you have a sort of personal sort of thought on some of the most likely sort of strategies that are going to be sort of prove successful? And I guess also it's going to be very much depend on the individual type of therapy that or the disease that the therapeutic is going to, the strategy is going to try and get tolerance to. But again, do you have any sort of particular thoughts on that?
Yes, I do. I mean, it's the increasing exploration, I think, of both nanoparticles, the nanoparticles with rapamycin. I think that's very exciting and a strong possibility for that might work, as well as the antigen-specific approaches, again, with all the caveats I mentioned. And I think it's somewhat ironic that the most successful tolerance induction protocol that I know of, is completely non-specific. It's a combination of rituximab, which wipes out all B cells, methotrexate, which is a global immune suppressive, and IVIG. And that's being used in patients with Pompe disease, for whom antibodies to the enzyme replacement therapy are life-threatening, life-terminating, actually. So it's somewhat ironic that, this is a strategy that's worked. Also, the strategies, and I didn't get into that, but where you completely obliterate the immune system and let it reconstitute. So that's been done for severe MS and in some other autoimmune diseases where you completely obliterate the immune system. It's needless to say, loaded with safety concerns, but in some circumstances it does work, and Larry Turca's done a lot of work on that. So ironically, I think that's what has been shown to be effective so far. But I think the emphasis really, and the Immune Tolerance Network is certainly working on this. The emphasis is trying to find much more antigen-specific modalities, and of course, antigen-specific means you have to know what the antigens are. And half the time, or most of the time, when patients are diagnosed with autoimmune diseases, you've had so much epitope spread, you don't even know what all of the antigens are. So it's a high bar, I would say, in some settings.
Yeah, thank you very much. It's great. Okay, any more questions? No. Okay, well, thank you very much, Amy. We really appreciate you joining us today. Thank you.
Yes, and thank you, and hope to be there another year.
Thank you. Bye-bye.
Take care.